It is not this year alone. Every Dibicon, he was the person behind it. He was the person behind. Thank you very much.
I want to wholeheartedly thank my manager who has been with me for the past month doing all this thing for me. Thank you very much.
I request Dr. Selvapandian to present a memento to him and welcome him on the stage. Photographer.
Good afternoon, everyone. I hope my voice is audible to the last row. The topic is actually very, it may be some kind of complex. I have tried to keep it very simple, not more than 15 slides. Maybe after 10-15 minutes we can have a brief discussion. The topic will mainly discuss issues related to role of inflammation in pathogenesis of type 2 diabetes mellitus. I will briefly mention about the pathways and the possible futuristic treatments available today. Generally, when we think of immune system and inflammation, a few things come to our mind. One is response to infection, to restore functionality in response to any stress. And second thing, in response to injury, if not infection, to injury. Generally, it happens to be a physiological response initially, but when it becomes prolonged, like in chronic inflammation, it causes deleterious changes in tissues. In addition to infection and injury, one of the common triggers of ongoing immune activation and inflammation is overnutrition, which is very relevant to our topic today. So generally, when we think of immune system and metabolism, these are two generally perceived as two unrelated issues. One is concerned with host defense, another is concerned with nutrient disposal. But when you look at the micro processes happening at the cellular level, these two are very much interconnected. The byproduct of one triggers another, and byproduct of another activates the system. So there is a very intricate interrelation between immune response and metabolism, which I will try to explain in the next few slides. Whenever we think of immune markers and try to correlate the presence of immune markers with cardiometabolic disorders, these are the following markers which come to our mind, which have been investigated in detail, like acute phase response markers including sialic acid, alpha-1 acid glycoprotein, serum amyloid A, C-reactive protein, cortisol, interleukin 6. Interleukin 6 has a special place which I will come to in a later slide. What we now presently know is that while chronic inflammation may be deleterious, limited inflammation definitely is adaptive, and it runs in support of the normal physiology. It can be beneficial to a limited extent. Let us say, for example, there is a limited hyperglycemic event. Let us say the sugar goes up a bit. What it does is it triggers the increased presence of IL-1 beta, followed by another cellular second messenger called FAS, upregulation. There are few other subsequent messenger molecules within the cell, like FAS engagement, flip protein, presence of flip protein. Eventually what it does is depicted in the blue box, beta cell proliferation and enhanced function via PDX1. So while we can ignore the complex second and third messengers, the final effect we have to note that there is a limited amount of beta cell proliferation and enhanced function of beta cell for a short period of time following a hyperglycemic event. So this involves some amount of immune activation and inflammatory process. So the point to note is limited inflammation is beneficial. I told that IL-6 has a special place in insulin physiology and pancreas physiology. What it does, it has been shown to induce GLP-1 production and secretion from intestinal L cells and pancreatic alpha cells. The pancreatic alpha cell part should be surprising because generally we know that it is secreted from intestinal L cells. But IL-6, what it does, it reprograms alpha cells to process proglucagon, already existing proglucagon, to GLP-1. Generally from proglucagon, glucagon is produced by alpha cell. It slightly modifies the internal process of alpha cell and produces more of GLP-1. So eventually there will be more GLP presence inside the pancreas near about the vicinity of beta cells. And another important point to note, IL-6 is secreted in response to muscle exercise. Whenever the muscle is put to some exercise, IL-6 is secreted. This could be beneficial. That could be one of the many reasons for the benefit which we see with exercise in diabetic individuals, because it induces GLP-1 production to a limited extent. But there are not many interventions associated with IL-6 at the moment. So this I highlighted as a case of interest, that there are molecules which can be manipulated, pulverized, used to benefit both the immune system as well as the beta cell physiology. Overall, coming to the overall picture, in pre-diabetic and diabetic individuals, adipose tissue is the crux where most of the pathophysiology takes place before pancreatic beta cell fails. Once pancreatic beta cell starts failing, the beta cell also starts showing pathologic changes, but that is a later stage event. First, everything happens in a obese pre-diabetic individual. The site of action is adipocyte. We can see three sets of figures here. The top one depicts the normal beta cell depicted in orange brick red, and the yellow cluster of cells is the adipose tissue. We can see we don't see any macrophage there. The second set of cellular groups we see is what we see in pre-diabetes. We can see there is a small hypertrophy of the beta cells. They have to secrete more insulin. It is depicted by a thicker arrow, insulin arrow. It is partly triggered because of the need to have more insulin at adipose tissue. At adipose tissue level, there is partial insulin resistance because of the presence of macrophage and subclinical inflammation. The macrophages are shown in blue in this slide. We can appreciate that. At the time of pre-diabetes, in an obese pre-diabetic individual, the main site of action is in adipose tissue, where there is subclinical inflammation in adipose tissue, which leads to some degree of insulin resistance. The insulin resistance leads to need for more insulin secretion from beta cell, so there is beta cell hypertrophy. Now eventually the inflammation spreads, that mild subclinical inflammation spreads to the vicinity of beta cells also. Macrophages secrete certain factors which kind of accelerate the beta cell processor and eventually exhaust the beta cell processes. We can see there is ongoing inflammation in the adipose tissue even when frank diabetes is ensured. So this has to be kept in mind, that this is one of the reasons why obese pre-diabetic progresses into diabetes more easily than a lean pre-diabetic. And coming to nitty-gritty of adipocyte inflammation, this is going to be a little complex to grasp. I will try to pause and allow you to look at the slide for 1 minute. There are two cells placed here, one depicted in orange and another in blue. The blue one is the macrophage and the orange one is the adipocyte. One of the pointer. Okay. We can see there is a protein showed here called fetoin A, and there is a set of proteins in the membrane called TL receptor 4. These are one of the triggering factors for the subsequent inflammatory markers within the cell. Whenever the glucose level goes up, free fatty acid level goes up, and endotoxin injury is there, endotoxin toxicity is there to the adipose tissue, there is a binding of endotoxin to TL receptor 4, or through some other process fetoin A is activated, which in turn triggers the activation of TLR4 related inflammatory processes. So these three are the main triggers: glucose, hyperglycemia, excess free fatty acid level, like after a heavy meal. Consistently, if we have a heavy feast, then it may trigger the subclinical inflammation at adipose tissue level. And third one is endotoxin, like in a bacterial infection. So eventually what happens, there is hypertrophy of fat cell. It can hold as much as it can hold. After that it gives way. Because of hypertrophy and accelerated processes within the adipose tissue, there is hypoxia. The mitochondria cannot exert beyond the limit, and the endoplasmic reticulum cannot handle the protein subunits folding beyond the limit. There is endoplasmic reticulum stress, and eventually there is cell death. The adipose tissue cell gives way. The whatever intracellular content pours out into the extracellular area, and subsequent inflammation occurs in the vicinity of that dead adipose tissue cell. So what happens in macrophage, you can see in parallel. Similar kind of apparatus is there in the macrophage also. TLR4 receptor, fetoin A. What happens is pro IL-1 beta is converted to active IL-1 beta. Macrophage also secretes another pro-inflammatory trigger called TNF, which is going to be subsequently discussed in another slide. These are all targets for therapeutic intervention. One is TNF, another is IL-1 beta. The inactive IL-1 progenitor or the pro-protein is converted to active IL-1 beta. And there is another pathway happening in the macrophage through reactive oxygen species, which acts through a set of proteins called NLRP3 and caspase-1. So there are multiple pathways happening. One of the pathways increases the secretion of IL-1 beta and TNF, which is going to be subsequently discussed. Now coming to what happens to beta cell, first there is inflammation, microinflammation at adipose tissue level, then this spills over to beta cell. Beta cell, similar set of events happen. We can see the more or less the same set of molecules here also. There are two red arrows shown here just to show that two pathways are operating. The glucose, free fatty acid and endotoxin can directly increase the level of reactive oxygen species within the beta cell. Beta cell is doing simultaneously two processes. It's like, suppose if you go to a shop, only one fellow is there. That fellow has to go to the inside of the shop, bring the product also, check the cash and put it in the counter and also give you bill. He is multitasking. Eventually he is put to stress because he cannot handle more than one person at a time. Beta cell is doing something similar. There are sensors on the surface of beta cell which sense the amount of glucose in the circulation and in the pericellular area. It also has to synthesize insulin, package it, pro-insulin, insulin, package it and secrete it. So beta cell is multitasking in that sense. It's very complex to develop a artificial pancreas precisely because of the same reason. The same apparatus has to both sense and intelligently secrete insulin also. So beta cell is very much multitasking. It is put to stress. So whenever there is excessive flux of events within the beta cell, what happens is too much of reactive oxygen species are secreted. Reactive oxygen species are damaging to the internal mechanisms of beta cell. Another pathway is happening through the typical inflammatory cascade through TLR receptor 4, TL receptor 4, T lymphocyte receptor 4. There are two receptors, TLR2 and TLR4. The eventual pathway is through caspase-1 or through NF-kappa B. Here also we can see there is excess secretion of IL-1 beta from beta cell itself. There is a auto inflammatory cascade from beta cell itself. Beta cell itself produces slightly excess of IL-1 beta. The same IL-1 beta exacerbates the inflammatory mechanisms in and around the beta cell. So the main players I would like to reiterate, one is microinflammation at adipose tissue level, excess secretion of free fatty acid, glucotoxicity. This glucotoxicity and excess free fatty acid go and attack the beta cell, increase the reactive oxygen species and increase the level of IL-1 beta and NF-kappa beta. I am reiterating this just so that I can come to this later in the therapeutic part. Now coming to therapy aimed at inflammation, like I mentioned, these are the four main molecular mechanisms which are targeted. One is IL-1. IL-1, there are two ways to target. One, the receptor is targeted, another IL-1 molecule itself is targeted. There is IL-1 receptor antagonist. The molecule which has been used in trials is anakinra. Second one is IL-1 beta antibody. It directly attaches to the IL-1 and prevents it from its further pro-inflammatory action. Third pathway is the IKK beta, NF-kappa beta. That is inhibited. If that is inhibited, the pro-inflammatory pathway can be arrested to some extent. And the fourth one I showed, TNF is secreted from macrophage in the adipose tissue, TNF antagonism. The names may be complex, but if you remember roughly the pathway, we can easily correlate. There is excess of TNF, excess of IL-1 beta, excess of reactive oxygen species. So the mechanism by which we can attack is through these molecules. So coming to one of the molecules, this is anakinra. There are a lot of short-term studies. The main carry-home message I want you to take is in the last line. Anakinra, actually the IL-1 antagonism mainly improved insulin secretion rather than insulin sensitivity. So the beta cell function improved after IL-1 antagonism. Most of them are short-term studies. The maximum one follow-up was for 39 weeks. Following the 13-week study, totally 52 weeks. Lot of minor benefits were seen, like insulin secretion was increased, sustained CRP reduction, HbA1c decreased, leukocyte response decreased, CRP decreased. So there was improvement both in surrogate markers like in pro-inflammatory markers, also in the glycemic parameters including fasting glucose, insulin secretion and HbA1c. So this is one of the molecules. Results have been promising, not yet out in the market. Long-term studies are awaited. The second group is IL-1 beta antibody. Here the receptor is not targeted. Directly the IL-1 beta is getting hinged to antibody. The antibody prevents it from exerting its pro-inflammatory action. Two molecules have been tried, Givokizumab and Canakinumab. I think they are running out of names, they are keeping funny names. So again here the mechanism is similar. The insulin secretion is improved rather than insulin sensitivity. There is a modest, all are short-term studies, 13 weeks, 16 weeks. So we can consider it as kind of preclinical, not yet ready for widespread clinical use. The third group of agent is salicylate, very popular, acetyl salicylic acid. We all use in the form of aspirin, similar to that, high dose. Here, even up to 48 weeks they have studied. There has been major studies published in reputed journals also. Here the last line I would draw your attention to, salicylate consistently improved insulin sensitivity. So it is acting on insulin resistance primarily rather than on the beta cell function. So it can be very much useful in obese diabetic individuals. In future that could become one of the indications if salicylate is proven to be beneficial in long-term studies. Lot of beneficial effects have been noticed in inflammatory parameters, fasting glucose, insulin. Having said all that, it is still in the preclinical stage, not yet ready for widespread use. Salicylate is already kind of approved, off-label use have been tried, but modest effect is very modest, 0.5% decrease in HbA1c. And fourth one is TNF antagonism. It is secreted from the macrophage, especially in the adipose tissue microinflammation stage. Again, we see the last line, we can see it mainly improves the insulin sensitivity. It works on the insulin resistance more than the beta cell function. Lot of short-term studies up to 6 months. Many of them are underpowered, so difficult to exactly tell how much it is going to benefit. Of the four, the more promising have been anakinra and salicylate of the four discussed here. Coming to side effects, we have to remember that we are playing with a very tricky system, the immune system. The more we meddle with it, the more we may face some undesirable consequences in future. Many of them in long term, gradual reduction in cellular immunity or innate immunity may be there, or a specific immune pathway may be affected, like that which is required for preventing primary TB to progress to widespread TB. Acceleration of tuberculosis upon TNF alpha inhibition is a well noted complication. Already the molecule has been used in many rheumatoid arthritis patients, so it is a fairly common side effect. And IL-1 antagonism minimally increases the incidence of acute infections. There is a side effect of inducing infection. Salicylates in general have mild effect and also mild side effect, so they may evolve into a possible adjunct drug in the future with longer term studies. I have primarily focused on agents which affect immunity and subsequently affect inflammation. Since the time duration is short, I have not touched upon antioxidants and altering gut microbial flora. There has even been a study where they took feces from a healthy individual and colonically, through colonoscopy, they put it in the colon and tried to alter the microbiota, gut microbiota. Subsequently was shown to have beneficial effect on parameters related to glycemia and insulin resistance. That field is evolving still, no final word is out, but little repulsive, but still it may have eventual some benefit. So those areas I am not touching upon because I am trying to keep my topic focused on innate immunity, related inflammation and subsequent worsening of diabetes where we can attack it. So these are the main points I would like to reiterate. Instead of looking for some very powerful anti-inflammatory agent to come and stop diabetes altogether, we already know that the most of the inflammatory process is happening in the pre-diabetic stage itself. In the pre-diabetic stage itself, even if beta cell function is near about okay, still some inflammation is going on in adipocytes, near about adipocytes, which trigger the secretion of all pro-inflammatory cytokines. So that should be the prime area of attack at the pre-diabetic state itself. Second point we notice with regard to IL-6, IL-6 is secreted in response to muscle exercise. IL-6 has some beneficial effect on GLP-1 secretion even from the alpha cell. So muscle exercise benefits in more than one ways. In addition to increasing the glucose uptake and improving the insulin resistance, indirectly it also leads to increased GLP-1 secretion. So exercise and preventing the progression of pre-diabetes to diabetes should be the ideal kind of anti-inflammatory preventive therapy rather than later resorting to some powerful anti-inflammatory drugs. This field is still evolving, no final word is out yet, so we will be seeing more and more of details about the discussed anti-inflammatory agents. Multiple drug combination, instead of using only one drug which has a very small effect, we can use multiple drug combination. It's an inflammatory cascade, it is not a one-step process. It starts somewhere, but it ends somewhere. In between there are 4 or 5 steps. So multiple drugs acting at different levels of inflammatory cascade may be more effective with less side effects. Long-term studies are needed. We already saw that glucotoxicity and lipotoxicity are the main triggers for reactive oxygen species generation inside the beta cell. So cutting over nutrition, and second thing as told, increasing physical activity. At least one member of immune family is involved, IL-6. By increasing physical activity, IL-6 is secreted more, possibly it increases the GLP-1 secretion. So cutting over nutrition and increasing physical activity improves different aspects of immune function without resorting to drug therapy and retards microinflammatory state. So that last sentence should be borne in mind. Thank you all for patient listening. It was nice interacting with you all.
Interaction. We can allow interaction now. Any questions?
Role of hydroxychloroquine.
I am sorry, sir, I have not come across any major trial involving hydroxychloroquine. Maybe I should go back and read. I am not aware. It's very much possible that a lot of agents having some immune modulatory effect have a beneficial effect on the beta cell and insulatase, low grade insulatase taking place even in type 2 diabetes. Many short term reports or anecdotal reports possibly would have been published, but to my limited knowledge it has not yet become part of any major trial or part of even off label use either in US or Europe. So I will go back and maybe I can give more information to you at a later stage.
If there are no further questions, I now request Dr. Krishna Kumar to present a photograph to our speaker and thank him for a wonderful lecture.